everyone. So we have three students in our group. First of all, my name is Hoang and I'm a pharmacy student. Patrick, who is a nursing student, and Nathan, who is another pharmacy student. We have select our grandfather as our patient for the presentation today. So when we first see the patient, his chief complaints was, I have to go to the bathroom more often now. I have to wake up at night to go to the bathroom, and I can't even sleep. It's really annoying. For the for the history of present illness, we have NT, who is a 76 years old man who got interviewed for the medication therapy management programs. Patient was diagnosed with hyperplasia more than 6 months ago, and a physical examination at that time showed that patient has an increase in the size of the prostate gland. Patient was prescribed Delta LA 4 milligram capsule to control the symptoms. However, his symptom is getting worse. Even he's currently taking that medication. For the past medical history, patient has benign prostate hyperplasia. He has hypertension. He has insomnia. He has depression, colorectal cancers, and chronic back pain. For past surgical histories, patient has a tumor at the gallbladder and the intestine. However, surgery was done. Those tumor was removed. He also has a cataract surgery just done a month ago. For family histories, he doesn't know any relative with any health problems. For social history, he's a non-smoker. He's never used alcohol. He's married, a retired man, has 4 children. He doesn't have any allergy with anything. For the medication list, we have lithium 300 milligrams, one tablet every morning. Gabapentin 400 milligram, one capsule every morning. Tylenol 500 milligram, take one tablet every 6 hours as needed for pain. Atenolol and clotrimazole, one tablet once daily. Delta LA 4 milligram capsule, one tablet every day. Multivitamin, one tablet every day. Prednisone, the eye drops, is still one drops on the right eye 4 times a week. For past examination, like we say, we only have a patient a physical exam show that a patient has increasing in the size. For lab, we don't have anything. However, we would like to have a symptom score, a maximum flow rate, a residue of the urines, the prostate size, and a PSA level. For diagnosis test, we don't have anything. After sitting down and discuss about the patient, we think this is the list that we need to work on the patient. First of all, it's very important, very high priority is patient definitely need additional therapy or therapy change for his benign prostate hyperplasia. Patient also has complained about the chronic back pain. It's not controlled by the Tylenol, so we definitely need additional therapy for that. He also has complained about the insomnia. It's difficult going to sleep. And there's a drug-drug interaction between the lithium and the thiazide. Definitely the patient needs to monitor on that. So next, Patrick will go over the somnol, and Nathan will go over the pharmacologic plan for the patient.
Thank you, Hoang, for introducing our group and our patient. My name is Patrick Montplaisir. I am a nursing student at MCPH University. I am going to present the patient's stated problem of benign prostatic hyperplasia in the form of a SOAP note. In the case of our patient, our problem is urinary frequency and retention that causes them to get out of bed at night to urinate. The patient states that I have to go to the bathroom more often now. The problem started about last year. It was documented by his physician during his last visit in February 2014. He states that he often has to go to the bathroom at night and during the daytime. The sensation is a dull pressure when he feels the urge to void, which is relieved by emptying his bladder completely. The treatment for the current treatment for this problem is a prescription of Detrol LA prescribed by his urologist. Our objective data is basically information that I was able to gather during the interview. Our patient was an alert and oriented 76-year-old male. His facial expression was appropriate to his stated affect. The patient's appearance looked appropriate for his age, and he was dressed appropriate to the season. His skin is pink, warm, and dry. The skin color is appropriate to his ethnic background. He was seated comfortably in the chair. There was no obvious deformities. He was able to ambulate without assistance or use of assistive devices. He was able to rise from sitting in the chair to standing, and he used using the chair to stabilize himself. His speech was also appropriate for his native language. My assessment of the patient is based on the patient's description of frequent urinary retention, difficulty starting a stream, and nocturia. The diagnosis that goes along with these symptoms is a nursing diagnosis of urinary retention, which is related to his enlarging prostate. Our plan nursing plan for helping alleviate this urinary frequency and retention is in our patient's case, he has a Detrol prescription that may need to be changed because he said that medication is not working, is not helping to control the bladder retention and the increased frequency. So after conferring with my pharmacy partners for this project, we determined that Flomax may be a more appropriate prescription for him. And Nathan is going to go into that a little bit more later in the pharmacologic plan. We believe that this may better control the retention that he's experiencing with the enlarging prostate. The nursing recommendation, from my observation, is a bladder retraining program, which is going to involve increasing his duration of voiding to 3 to 5 minutes, rather than ending his urination when the urge stops. The goal is to decrease the patient's frequent urges and promote a more complete emptying of his bladder. Other teaching points is going to be to possibly increase the patient's consumption of caffeinated beverages if he's not currently a consumer of caffeine, which is going to increase diuresis and increase the amount of urine he produces in each occurrence. Another plan is to also create a round-the-clock urination schedule to complement his natural urges to urinate. For example, he could plan to void when he wakes up in the morning, when he has lunch, when he has dinner, right before he goes to bed. These are going to be 4 scheduled times throughout the day that he's going to go to the bathroom and sit on the toilet and attempt to void. This is going to complement his natural urges to void, as I stated earlier. Hopefully this is going to help him empty the bladder and get him to not go to the bathroom as frequently. So this completes my SOAP note for the patient's stated problem of benign prostatic hyperplasia. Now Nathan will present the pharmacologic plan for this IPE presentation. Thank you.
So my name is Nathan Mandel, and I am the other pharmacy student that's been working on this case. So I'm going to give you the goals of therapy, our pharmacologic plan, our non-pharm plans, monitoring parameters, and stuff like that to wrap this patient case up. So following what Patrick just said, with the subjective and objective criteria, the pharmacy students also believe that this is a case of BPH that is not well controlled. So our goals of therapy going forward would be to improve the patient's quality of life. We would like to decrease his frequency of urination, his urgency, and especially the nocturia, which is keeping him up at night. We'd also like to decrease the occurrence and severity of the symptoms, like I just said. Delay the clinical progression of BPH. We want to do everything we can to keep him from having surgery. We want to delay the need as long as possible and hopefully prevent it entirely. Lastly, we want to provide a cost-effective means of treating BPH with maximizing efficacy and minimizing adverse drug-related events. So our pharmacologic plan is to start the patient on tamsulosin 0.4 milligrams by mouth once daily at bedtime. We'd like to do this in combination with finasteride 5 milligrams by mouth once daily at bedtime. Time and again, this combination is proven to be the most efficacious route. We do need to monitor him for signs of hypotension and other things that I'll get into a little bit later on. But this is not only the most effective, but it's also the most effective in terms of pharmacoeconomics. Even though we are starting on 2-drug regimen, if we can prevent him from needing surgery or having recurrent UTIs, this is a more cost-effective way to go for both himself and his insurance. As far as our non-pharm plan, we would like him to maintain a healthy lifestyle. He needs to continue eating a low-fat diet that's full of fruits and vegetables. We're glad that he does not smoke. We would encourage him to continue to stay smoke-free as well as abstaining from alcohol. We'd also like to see him exercise regularly. 30 to 40 minutes, 3 or 4 times a week, nothing more strenuous than walking some stairs or walking around his house or his yard. It doesn't have to be too much, just enough to get his blood pressure up a little bit. We'd also like him to start on behavior modification. This includes restricting drinking fluids close to bedtime. So if he decreases his fluid intake at bedtime, that'll help decrease his nocturia. We'd like him to minimize his caffeine and alcohol intake. And the caffeine can also be in things like tea, green tea, different things like that. So we want to make sure that he does not drink the caffeine, especially close to bedtime, because this will also increase his need to go to the bathroom. But we would like to see him also empty his bladder frequently while awake. This will decrease his urine retention, and that will help with his need to go as well as the hesitance when he does go. As far as monitoring parameters, the most important thing that we need to monitor, at least in the short term, would be his American Neurologic Association or AUA symptom score index. This will give us the best short-term indication of how he's responding to therapy. It would also be nice if we could monitor his peak average urine flow and post-void residual urine volume, and we can do this once every 3 months or so. For long-term monitoring, we would like to monitor his prostate-specific antigen or his PSA levels probably once a year. This has been shown to correlate very well with BPH progression as well as prostate cancer. Lastly, we would like to monitor his prostate size every couple of years or so, and this will be a good indicator of when or if he will need surgery. Toxic adverse events that can be associated with this combination drug regimen include vital signs, especially his blood pressure. So first dose syncope and orthostasis are very common, especially with the tamsulosin. So we need to monitor that closely, especially in the beginning. We'd also like to monitor his renal function, which would be his blood urea nitrogen and his serum creatinine. Then as far as adverse effects go, this can cause erectile dysfunction, decreased libido, abnormal ejaculation. So if he's having sexual side effects, we need to take care of those. We can either give him medications to alleviate those problems, or we can decrease the medications that he's currently on. We also need to watch, like I said, for dizziness, postural hypotension, asthenia, peripheral edema, dyspnea of somnolence, and allergic reaction. So the patient needs to monitor for any rashes, shortness of breath, or hives. Anything that shows that he's having an allergic reaction, he needs to discontinue the medication immediately and call his healthcare provider or go to the emergency room. For follow-up, we'd like to schedule a follow-up visit so we can check his labs in 2 to 4 weeks and monitor for the dizziness and the postural hypotension. Also in 2 to 4 weeks, depending on the patient's response to therapy, we can increase the tamsulosin dose from 0.4 milligrams to 0.8 milligrams. As far as patient education, tamsulosin should be taken 30 minutes after the meal at the same time every day. So this is a difference in the guidelines that initially stated that the patient should take them at bedtime, which would help with the changes in the blood pressure. So the new guidelines say 30 minutes after a meal at the same time every day. Our recommendation would be to take it 30 minutes after dinner at the same time every day, because this is closer to bedtime, and that way, if he does have blood pressure problems, he should be going to bed anyway. Much better than taking it with breakfast and then having the blood pressure problems all day. Tams lotion should be swallowed whole. It should not be crushed, chewed, or opened. So he does need to take it whole. Avoid grapefruit or grapefruit juice with Tams lotion. This can cause side effects, as it will increase the amount of drug that's in the patient's system. If you miss a dose, take the missed dose as soon as you remember, and then return to your normal schedule the next day. You should not double up on mixed doses. If you do double up on missed doses, you're going to have major blood pressure problems. So just take one at a time. If you forget, take it as soon as you remember, and then just continue with your normal schedule the next day. You should start to see results in the first couple of weeks, but unfortunately it may take up to 6 months or a year before you see the maximal results. So this will be a slow process, but stick with it, and hopefully it will bring you the best outcomes. Thank you for listening to our patient case, and we look forward to seeing you in class.